So guys, now let's start with the regional neuroanatomy, and first we'll approach the spinal cord. And let me tell you what our approach in the spinal cord will be. First, we're going to look at some external features in which we'll talk about the extension of the spinal cord, and we'll see till where the meninges will go, what is the ideal site for the lumbar puncture. We'll talk about some spinal parameter modifications also. And then directly we go to the transverse section. We'll look into that what are the gray matter and the white matter area in there. And the approach to the gray and white matter will be that first we'll be looking at the gray matter of spinal cord, because we need to understand that where the fibers from outside are coming to, which nuclei of the spinal cord, and from that which respective nuclei the second order neuron will start and will give rise to the ascending tract, spinothalamic or dorsal column or whatever tract it is. So to understand these tracts in the gray matter, our approach has to be first we need to know about the gray matter, so that you understand that where the fibers are coming from outside into gray matter, and then from gray matter into the white matter and how it reaching the brain. And once we're done with all the major ascending and descending tracts of the spinal cord, at the end we will also talk about some major syndromes like Brown-Séquard syndrome, the central canal syndrome, the cauda equina syndrome, and the conus medullaris syndrome, and their differentiation also. So let's get started with the external features of the spinal cord, and we are talking about the first thing first, that is extent. Now, what is the extent of spinal cord? Now, we do not count the spinal cord from the foramen magnum, because we just said foramen magnum is giving passage to the lower part of medulla oblongata. So when you start looking at the length or the extent of spinal cord, never say medulla oblongata. We have to count it from C1, first cervical vertebrae only, first cervical level. So in adults, the spinal cord extends from C1 to lower border of L1. It extends from C1 to the lower border of L1. Whereas in newborns or neonates, the spinal cord extends from C1 to the upper border of L3. Upper border of L3. So remember, it is C1, that is L1, this is L3, and just be precise about it, that is the lower border of L1 and this is the upper border of L3 in neonates. Vertebral column and spinal cord, they obviously undergo a differential growth. So the pace and to the extent to which vertebral column will grow or develop, spinal cord will not go to the same length. And that's why spinal cord itself is ending at the lower border of L1. But obviously the nerves which are coming out of the lower part of spinal cord must be having the lumbar and the sacral nerves. So they cannot come out from that same level only. And that's why those nerves will go downward and will keep coming out from their respective intervertebral foramen. And that gives rise to a tuft of nerve present below L1 level, which we call as cauda equina. It looks like a tail of a horse, so then we call it a cauda equina. If I try to represent this thing diagrammatically, guys, so if let's presume this is the base of the skull here. Let's say here's the spinal cord, and as we said, we got two enlargements. In the spinal cord, you will also appreciate two enlargements. This is the terminal part of the spinal cord, I should say. This is the conus part. We call it conus medullaris. This conical projection is conus medullaris. And here we have an extension. This is still not the end of the spinal cord. So you will see a very thin extension from the conus medullaris, which is going to the dorsum of the coccygeal vertebrae, and that is called as phylum terminale. Let's take it one by one. First thing first, guys, we said the lower end of spinal cord. If I mark it like this, this represents the lower end of the spinal cord as such, and that goes till the lower border of L1 vertebrae. This here is L1 vertebrae. And this tapering part here below is what is this called as? This is called as the conus medullaris. This is conus medullaris. What exactly nerve will be present here in the epiconus part or conus part, and in the lower part? We will be discussing that with the syndrome only, because that will make more sense there. So we can pay attention to other things as of now. This extension of the spinal cord, guys, try to label it in the lower part only. This is called as phylum terminale. You can call it phylum terminalis or phylum terminale. Now, there's a bit more to discuss for phylum terminal, because in generally in book says that phylum terminal is an extension of pia mater of the spinal cord, which is true, but that is partly true. Now, why I'm saying it is partly true, because there is a point from where you will see phylum terminale is a modification of actually all three meninges also. We'll come to that part. Now, before we go to this phylum terminale and the division of the phylum terminale, which one is internus, which one is outer externus, I want you guys to again look back in the upper part, and here are the two enlargements we are looking at. Well, one enlargement that you see here is present in the cervical, and this is the lumbar region, so we call them cervical or lumbar enlargements. This is called as the cervical enlargement. So we got a cervical enlargement. And the lumbar enlargement. Well, that's because of their location. Cervical and lumbar enlargement represents what? Why can't we have a uniformly cylindrical spinal cord? Because, you know, when you think about the development of body, the upper limb and the lower limb develops later, a little later. So you have a spinal cord, we have a neural tube which is giving rise to spinal cord. But when the upper limb and lower limb develops, we have more amount of gray matter and white matter accumulating in that part, giving rise to the brachial plexus and lumbar plexus. So that means this is that portion of the spinal cord from where the brachial plexus nerves will come out mainly. And that is this part of the spinal cord from where the lumbar plexus nerves will come out and supply the lower limb. And that's why these parts are slightly enlarged, because we have more amount of white as well as gray matter inside. So cervical enlargement, because it gives rise to brachial plexus, you should remember the level of the cervical enlargement is C3 to T2. The level is C3 to T2. So C3 to T2 nerve will be seen coming out from there. And you can see the brachial plexus is all inside, guys. Brachial plexus, usual root value for the brachial plexus is C5 to T1. And lumbar enlargement, it extends from L1 to S3. L1 to S3. The nerves L1 to S3 will be coming out from there. So we call it L1 to S3. Now here's the point. The people get confused when they look at how can it be L1 to S3 when the spinal cord is ending at the lower border of L1. Well, there's a difference between the two things. That L1 over there is the vertebral level. I said spinal cord is extending till the lower border of L1 vertebrae. But that doesn't mean that L1 nerve is also coming out from here. This lumbar enlargement is the part from where L1 to S3 nerves are coming out. So these are not the vertebral level, these are spinal segments. These here are not vertebral level. C3 to T2 and L1 to S3, especially L1 to S3, you have to remember, because it's in the lower part, it can confuse people. These are not vertebral level. These are what? These are spinal segments. So these are precisely the spinal segment which is giving rise to the enlargement. So if you take this lumbar enlargement and you slice this lumbar enlargement, you will see, okay, these are the nerves which are coming out from this part exactly. We have L1, L2, L3, L4, L5 nerve coming out from there. So although we call it lumbar enlargement, but you can see even sacral nerves are also coming out of it. So be careful, that's spinal and that is vertebral level. Spinal cord ends at the lower border of L1 doesn't mean that meninges are also ending at that level. Dura mater and arachnoid mater, they both will extend till the body of second sacral vertebrae. So if let's say I'm just putting up this line here, and this represents the body of S2, body of second sacral vertebra. Now this is the level to which you will see what extending? The dura and arachnoid. So let's say if this is a dura mater here, you will see it is coming till this point here. Dura as well as the one which will be inside, that is arachnoid mater. So just drawing it very dark here so that you don't miss this part. That line here is corresponding to the dura mater as well as arachnoid mater. Dura or arachnoid mater. So it's a two different question. Spinal cord extending till the L1 level, but not the meninges. Meninges are going beyond it. You can see the dura and arachnoid, they are coming till the the body of second sacral vertebra, which tells me that this portion of spinal cord, guys, look at this, the part which I'm pointing at right there. This is kind of safe zone for the spinal cord, because having meninges still here, that means we do have CSF in this region for sure, but there is no spinal cord. Spinal cord is ending there itself. So below L1 until the body of S2, I can use this region for the lumbar puncture. If I put a needle inside, thankfully there is no spinal cord which can be punctured, but we do have CSF because the meninges are extending that level till that level, and that's why between L1 to S2, and most preferably somewhere in between L3, L4, if I take the ideal site, L3, L4 is the most preferred site for what? Lumbar puncture. Preferred site for the lumbar puncture. You can always do the lumbar puncture from a one segment above or one segment below. We can do that, but L3, L4 is the standard. Is the standard. But yes, we avoid doing the lumbar puncture from very lower part, especially when you say L5 and S1, we don't do that usually, and especially at the older age, because there are very good chances that the last lumbar vertebrae might be fused with the sacral vertebrae, something called as sacralization of lumbar vertebrae. So if you have, there are good chances that if you see an old patient, in that the L5 vertebrae might be fused with the sacrum, called as a sacralization of lumbar vertebrae. So why to take such risk? So we do it from the standard site, usually that is L3, L4, somewhere between L3, L4 being the site for the lumbar puncture. Now coming back to filum terminal, guys, we said filum, there's something more about this filum terminal. Filum terminal is considered to be an extension of spinal cord pia mater. Now imagine this pia mater will be adherent to the spinal cord all the way. So we have the pia mater running along with it till here, till conus medullaris, and from this point, the pia mater is the one which is extending downward as this thin extension and going to the coccygeal vertebrae. This, if you've not written, this is the dorsum of the coccyx or simply coccygeal vertebrae, and we call it filum terminal. So I can say filum terminal is made up of pia mater, true, but pia mater is extending till from this point till this point here, because at this point we have all the three meninges finishing. Pia mater coming till here, dura and arachnoid mater is also coming till here, and they're all fusing with each other, and then they're giving this extension further, and that is called as filum terminal externus. So I can divide the filum terminal also in two parts. If I write this alphabet for the guy, this is filum terminal internus, I'm writing I for it, and this here is the filum terminal present outside, that is I'm writing E for it, filum terminal externus. So filum terminal, wherever you've written it, filum terminal, there is an internus part and filum terminal externus. This filum terminal internus is a modification of only pia mater. Only pia mater forms internus, but filum terminal externus is a fibrous band. It's better you write it down, that fibrous band. It is actually a fibrous band. It is a fibrous band made up of, condensation of all three meninges, made up of pia, arachnoid as well as dura, all three. If simply they ask you a question about filum terminal and you have to choose one best answer, that it is a modification of what, obviously your best answer is pia mater, because that is there in the filum terminal internus also, externus also. But if the question specifically asks you about the internus part or externus part, or maybe they will give you this question with the level of spinal cord, ki above S2 level and below S2 level, what about filum terminal? So above S2 level is internus part, that is made up of pia mater alone. Below S2 we have filum terminal externus, where all the three meninges will fuse together and give rise to the externus. So we have modification of all three meninges forming the externus. Now I'm not discussing that part as of now, because as I said, I'm keeping it for the last in the spinal cord. But as you just saw that the conus medullaris, if this was the conus medullaris part, and there is a upper part of the spinal cord there, and here we have the filum terminal coming to the coccygeal vertebrae. And so what I'm trying to show you here is that the nerves which are coming from the different level, like we have a nerve which will be coming out like this and let's say emerging at this point here. We must be having nerve which is coming out even further and emerging out at this level from the respective intervertebral foramen, and so on. The nerves will keep coming down here, and they will keep on coming out from the respective part of the spine, respective part of the intervertebral foramen, and that is the one, which is giving rise to this cauda equina. So the differential growth in the vertebral column and in the spinal cord gives rise to the cauda equina, because the nerve has to come out from the respective part only. And because spinal cord is lesser in size compared to the vertebral column, so the nerve, they make a tuft and then they go out from the respective foramen, leading to this horse tail-like structure called as cauda equina. So knowing the anatomy of this part is very important to understand one syndrome we'll discuss a little late, that is called as a cauda equina syndrome. Because if the injury is in here, if the injury is to this part, only this part here, if this is injured, so obviously we'll call it what? Cauda equina syndrome. That will be a cauda equina syndrome. But if the injury is here in this part, then we call it what? That is the conus medullaris syndrome. I'm writing CNM, that is conus medullaris syndrome. The reason I'm telling you about it here itself, because I keep at least one thing in mind, that when there is an injury to the cauda equina, so it is more of a lower motor neuron type of palsy. We have a lower motor neuron. Nerves are involved. It's a peripheral nervous system which is involved in this. Nerves are involved. So I would say it's a peripheral nervous system which is affected in the cauda equina. The nerves only, it's cauda. But when you look at the injury at the level of conus medullaris, let's say if the injury is at this level, so obviously, first of all, it is a type of injury to what? CNS. It's an injury to the spinal cord directly, so we have injury to CNS. And on the side, you can see some nerves are coming out and down. So this is also will show some feature of injury to PNS, peripheral nervous system. So when you're thinking about the features of the cauda equina and conus medullaris syndrome, you have to, the first thing that should stay in your mind is that cauda equina syndrome is all about the injury to the peripheral nerves. So the symptoms will be based on that. And when you look at the conus medullaris syndrome, it's a part of spinal cord involved. So that is CNS. And obviously the nerves are going from the side of it. Those nerves can also be involved. So we also can have some peripheral nervous system symptom as well. So it's a CNS-PNS mixture type of injury. But as I said, we still have to know a little more about the spinal cord before we reach that syndrome region. So first, continuing with this features of the spinal cord, guys, we saw the extension and everything. In the meninges, we just said about the spinal pia mater is forming this phylum terminal. That is one of the modification of spinal pia mater. Spinal pia mater is special because it gives rise to some other things as well. Like there are some other modifications we have for the spinal cord pia mater. So when we talk about the spinal cord pia mater modifications, one, as we just said, is the phylum terminal. One is the phylum terminal. Both internus, externus, it is there in both of them. One is very, very important. That is called as, one is called as linea splendens. Let me tell you that this one first. That is linea splendens. Linea means line and splendens is white. It's a bright white line called as linea splendens. And number 3, which is surgically important, that is the ligamentum denticulatum. Ligamentum denticulatum. Ligamentum denticulatum. Well, we already had this tick mark on the phylum terminal. We know about it. Now coming to what is linea splendens, guys. Well, you must have noticed when you look at the spinal cord in the transverse section, if you look at the spinal cord in the transverse section, on the posterior side of the spinal cord, now let's say this is the gray matter and white matter, you already know that. On the posterior part of the spinal cord, we do have a septum. We simply call it posterior median septum. There is no space on the dorsal aspect. When you see the dorsal aspect of the spinal cord, there is no space. We simply call it septum. But anteriorly, there is a space in the spinal cord, and that's why it is called as a fissure. We call it anterior median fissure. This is referred as anterior median fissure. And this anterior median fissure is filled with the pia mater. Now, obviously, pia mater is running on the surface of the spinal cord. Like anywhere else, it is running on the surface. That is a pia mater. And I already told you that pia mater is the most faithful layer of the brain and spinal cord. So it not only runs on the surface, wherever it finds a scope, it goes in that ditch also here. So like this, it is filling of this fissure, that pia mater, and because the pia mater get filled inside, let's say this green color here representing the pia mater, if the pia mater fills inside, so this gives right like a line like appearance in front of the spinal cord. That's an anterior part of spinal cord. So when you look at the spinal cord, you will see that it looks like there is a white line running in the center of the spinal cord, and that is what you call as the linea splendens, guys. This is what you call as a linea splendens. It's a bright white line right in front of the spinal cord, which is nothing but the pia mater filled inside the anterior median fissure. Next in the line, ligamentum denticulatum. What is ligamentum denticulatum? If let us imagine the spinal cord in a longitudinal section here, let's say this is the spinal cord. I'm just drawing it very rough diagram here. That's the spinal cord. Once again, the pia mater will be adherent to it. Now this pia mater, what you will see, it sends off these extensions, these tooth-like extensions on the side of the spinal cord, which is connecting the spinal cord with the arachnoid mater on the side. So this tooth-like projection, which is made up of pia mater only, that's why the name is denticulatum. These are called as ligamentum denticulatum. These are what you call as the ligamentum denticulatum. Ligamentum denticulatum. Now, if I have to show you a ligamentum denticulatum in the transverse section, how will it look like, guys? Something like this, exactly in the center, like this. This is like the ligamentum denticulatum are when you see it in the transverse section. Now, as I said, these ligamentum denticulatum, they have some important surgical relevance here. The reason they are important is because they lie exactly in the center, exactly in the midline of spinal cord. So they can be used as a surgical landmark when you're doing the sectioning of the spinal cord. Now, let us say you have to cut the spinal cord for whatever reason it is. There is an interactable pain is there, so you might have to cut a dorsal horn of the spinal cord, or you may have to compromise the ventral horn of the spinal cord. So what you're going to do is, what a surgeon is going to do when they start cutting the spinal cord, they will stop at the ligamentum denticulatum here, because that can be seen from the outside only. You cannot peek into the transverse section of spinal cord, so you just have to cut the spinal cord. Like this is the spinal cord here, so I have to cut it from the outside only. Now, how do I know that till what level I'm reaching? Am I cutting exactly till the half or going beyond the half? That's where this ligament will come into the picture. So this ligament is on the side here like this. So if I start cutting it here, and once I'll reach this level of the ligament, I'll come to know that exactly half of the spinal cord is already cut. So this will prevent the surgeon from going beyond a certain point. And that's why, if just so that you remember it, I'm just drawing a scalpel here. So if you're doing the anterior posterior sectioning of the spinal cord, this will act as a landmark. So I can write this, that ligamentum denticulatum is it's a neurosurgical landmark for anterior posterior or posterior anterior, vice versa, anterior posterior sectioning of spinal cord. Anterior posterior sectioning of spinal cord. Now the question here is that how many ligamentum denticulatum we have, total number of ligamentum denticulatum. The mistake we do here is that we start counting the projections here. The question is not about how many projection is having in the ligamentum denticulatum, how many ligamentum denticulatum we have. So we only have 2 ligamentum denticulatum. This whole thing is 1 ligamentum present on the right side, and this is 1 ligament which is present on the left side. That is a single ligament, guys. So answer to the number of ligamentum denticulatum is 2. The question is about number of ligamentum denticulatum. We only have 2 ligament, but yes, every ligament is having 21 projections. Every ligament is having 21 projection. So we have 21 pairs of projection coming out. So these 2 ligamentum denticulatum, they are having 21 pairs of projections. 21 on each side, so 21 pair of projections. So there are 2 different questions, number of ligamentum denticulatum and number of projection from 1 ligamentum denticulatum. So we have 21 projection from 1 ligament. So this is a little bit about the external feature. We saw the extent of the meninges, also some modification of the meninges. Now let's get inside the spinal cord, or let's talk about the internal feature of the spinal cord. And we, as we said, will start first with the gray matter part. So we have to look into the internal thing to understand that what tracts are supposed to come there and which sensation they will relay there. And after that, we can talk about the ascending and the descending tract. So what we're discussing, this is all in very, very sequence here, because everything that we're discussing right now will make a lot of sense in the brainstem also. We have discussed the cranial nerve nuclei and the cranial nerves already in the head and neck part, and now we are looking at this spinal cord internal features, and also about the tracts in the spinal cord, which lemniscus they will form. And ultimately, these tracts of the spinal cord are related to the brainstem only. Either they are going up or going down. So when we talk about the brainstem syndrome, you have to know about the spinal cord, which spinal cord tract is coming there and in which form. And also, is it running on the ipsilateral side or contralateral side as well.